Okay, afternoon everyone. As a committed caffeine addict myself, I'm aware I'm all that's standing in between me and coffee, most importantly, so I'm going to try and be quick. For those of you who don't know me, my name is Mark Terris. I'm one of the consultants in paediatric intensive care and anaesthesia in the Children's Hospital, and also clinical lead for paediatric transport as part of the NISTAR team. First disclaimer, I'm in no way an expert in seizures or epilepsy. I'm kind of looking around the room, recognising a few faces I know and feeling entirely unqualified to give this talk, so bear with me. Seizure is something that we fairly commonly see in intensive care, so it can either be the primary reason for the child's admission, and that can either be as a status, ongoing seizure activity, or more commonly perhaps the children who are just sleepy post-treatment, who have responded badly to their benzos and come to us for a spell for support. It's also something that I think a couple of the speakers have mentioned through the day that we will see in our children who are in for other pathologies. So we see it in children who are septic, we see it in children who have arrested as well. So it's something that we all have to be familiar with. Kind of presenting spectrum in terms of cases, well, that's so varied, it's difficult to say. So your 3-month-old that comes in with seizures and has an underlying metabolic disorder, your 2-year-old prolonged febrile convulsion, your 6-year-old known epileptic, your 14-year-old who's dragged in out the Falls Park fitting, having ingested something. So it's difficult to kind of pick, but fortunately the principles and approach are same pretty much regardless of age. So what is status? How do we define status? Silence. Oh my God, he's asking questions. So the kind of standard definition that everyone will use, we talk about 30 minutes. So either ongoing seizure activity without recovery of consciousness for 30 minutes, or intermittent seizure activity with breakthrough but no return of consciousness. And again, this 30 minutes is kind of bandied around. I think it's a fair definition to use. Clicker not working. The other definitions that are out there that are used then, so I like this slide for a couple of reasons, mainly because the group that came up with this, the ILAE, anyone ever heard of them? The International League Against Epilepsy. Now those people wear capes. They must do. They came up with this definition quite recently, or tried to come up with perhaps a better definition. They just kind of discreetly broke it into 2 groups. So your operational dimension 1 and 2. 5 minutes for your tonic-clonic status epileptic patients. 5 minutes is important because children who seize for less than 5 minutes are likely to self-terminate their seizure activity. You probably will not have to do anything other than kind of fairly basic supportive measures. And many of these children will stop fitting before they reach you in hospital. Children who fit for longer than 5 minutes, the cycle is starting to wind up now, and it's less likely that's going to break spontaneously. So more likely you're going to need to treat. And that's where our 5-minute kind of treatment threshold comes in for the initial dose of benzos that we'll come to. Children who go on to fit for longer than 30 minutes, so that second time scale they put in there, those are the children that are now getting into difficulty. So that brain has probably started to starve itself of oxygen. You're starting to get the kind of metabolic catecholamine-driven storm that comes with a prolonged seizure. And this child is now shifted to the point that they're in danger of having permanent long-term sequelae from this seizure episode. So we need to do something. Other definitions that are out there then, so refractory status epilepticus, so that's any child who doesn't respond to 2 doses of benzos basically and continues to seize. Super refractory status epilepticus is status or seizure activity persisting for more than 24 hours despite kind of good anaesthesia intensive care management. And that can be a child who seizes, stops seizing, starts seizing again. Prolonged refractory status epilepticus, it's quite hard to say, that's status lasting for more than 7 days. Something I don't think I've ever seen or been aware. Perhaps my children in my care have been doing it and I just haven't realised. And prolonged super refractory is children more than 7 days with and without anaesthesia. Norse and Fires. Fires I put up here specifically because I was at a meeting a couple of years ago and the guys from Dublin were presenting their experience of children with Fires. I'd never heard of it, and it was one of those things I felt too stupid to ask the question. Norse, many of you know, I'm sure, it's a new onset refractory status epilepticus. Essentially status in a child that you probably can't find a really good cause for, so it doesn't appear to be secondary to another reason. Fires is probably a subgroup of Norse. Fires is febrile, I have to look at this, febrile infection-related epilepsy syndrome. So a child who's had a febrile illness in the preceding kind of 28 days to 24 hours and then presents febrile or non-febrile with a status epilepticus episode. They're a group that there's a lot of work going on around in terms of outcome and perhaps a slightly more concerning group. So importantly, we've mentioned how children do. I think I'll confess, as an intensive care consultant, this is possibly something I don't pay much attention to. Seizures and status kids are a group of children that, to us, are a lot of work for minimal outcome. So many of these children will come to us and be extubated within half an hour of arriving in the unit. So quite often, and I'm sure many of you will have had the vibe when you refer these kids to us, we're a little bit grumpy about them because we know we're going to have to go out, 2 hours in the ambulance, half an hour, 2 hours back, and then we're going to wake the kid up. What's the point? Well, that's the point, I think. You're talking about a condition that's got a mortality of approximately 5%. Admittedly, most of the children who die with seizure-related deaths will die before they get to any of our care from hypoxia, loss of airway, cardiac arrest potentially, or will be discovered dead. Morbidity, still significant, so 6% in children over 3 years of age. Much higher morbidity associated with children under 1 year of age who present with seizures, and that's primarily because that tends to be etiology driven. So these children are fitting for a reason, and I think it's the condition that's triggering the seizure that probably accounts for that morbidity. But still, significant numbers. 1 in 3 of your patients will present and suffer long-term morbidity. Treatment, apologies, this won't project well, but you all know it anyway, so I'm trying not to make this an APLS lecture, but this is an APLS slide, as many of you will recognise. What do you do? So ABCD, you're going to maintain the airway as required. You're going to get 100% oxygen on them by non-rebreather. You're going to get decent access, and then you're going to start treating the seizures. So first time set is 5 minutes. Now generally by the time these kids arrive in your ED department, they will have received a dose of benzos by the frontline crew in the majority of occasions. Your next dose is going to be given at 10 minutes, and at that point you can also start thinking about paraldehyde. I'm old school, I quite like paraldehyde. A, it works, if I'm honest. B, it also smells lovely. C, the smell tells everyone else in the department what's going on. The minute you walk into your general ward and smell paraldehyde, you know you've got a fitter in the department. It's great. So as you're preparing your phenytoin, you can be drawing up and getting the paraldehyde ready to administer. So second dose of benzos, another 10 minutes, it's still not working. Then you're going to progress down onto your kind of third level therapy, I suppose. So we're now into the patients who are going to get phenytoin or phenobarb, depending. So your neonates, generally phenobarb, your children who are on phenytoin maintenance, phenobarb, and then the rest of the kids are going to get phenytoin. Phenytoin is one of those bugbear drugs. Again, many of you will have faced this, I'm sure. At the point you're told to refer the child to intensive care, the phenytoin is still running. What's the stock response from intensive care? Ring us when it's done and let's wait 20 minutes, I'm hearing. Entirely. So many of these children are referred at this point when possibly we're not going to change anything. We're going to walk very slowly to your department so that we are there 15, 20 minutes after the phenytoin's in. And quite often that works, if I'm honest. The kids have stopped seizing and we're probably no longer required, occasionally still required. If that doesn't work, then you're into the kind of the APLS, the end of APLS. So you're on the phone to intensive care, you're talking about anesthesia and kind of next level treatments. So that's your rapid sequence induction with thio and probably ROC, although SUCs may have benefits in terms of allowing the child to recover muscle function so that you can see ongoing seizure activity. Always be careful a child who you know is fitting that you have paralysed, because obviously you lose some of the clinical monitors. One of the reasons we are so grumpy about these kids coming into the unit is it is very difficult for us to then assess that, and the child can be quite happily lying there fitting away, and oftentimes we won't realise. What are we going to do when we get to intensive care then? So what comes beyond that first dose of thio? Well, that varies. Various units will have different protocols. Broadly, it's going to be either more midazolam or thiopentone. Midazolam infusion may have some benefits. Thiopentone is a fairly old, fairly dirty drug, particularly by infusion. And certainly we will tell the parents if your child's going to a thio coma and a thio infusion that if we run it for 2 days, they'll sleep for a week. They'll need a central line because they'll drop their blood pressure, and there's a high chance that they'll end up with a secondary associated infection, most commonly a ventilator-associated pneumonia. So it's not something that we embark on lightly, and certainly has to be something that's done with EEG monitoring. Just a quick mention of this concept, which is a very interesting study for a couple of reasons, has finished recently. It hasn't fully been reported and certainly isn't published yet, but the authors have presented, so we do already kind of know the results, but without too much detail. Essentially, interesting study for the first reason in that this was a deferred consent study. So basically, following the first 2 doses of benzos, if you didn't stop fitting, you were then randomized to either receive phenytoin or Keppra. I'm not going to attempt to pronounce its proper name, it's Keppra. And then looked at outcome. And then consent was sought from the families after the fact to see. What it shows, what we think it's going to show, is basically no difference. Both drugs work. Both drugs stop seizures. Why is this good news? Well, it's not phenytoin. So phenytoin, for anyone in the room who's ever had to calculate dosing, calculate administration rates, will understand the headache involved. It's a slow drug to give. It's a not terribly clean drug in terms of its side effect profile. So I think if we can get rid of phenytoin, ban it to history, then this is a step forward. So watch this one with interest once it finally reports, and see if we're going to see some changes in the algorithms and the kind of the management that we expect. So once the child's in with you, kind of touched upon this a bit, I suppose. Why is this child fitting? And it's important that you cast that net fairly wide. On the right-hand side, that table deliberately doesn't project well because that's just one of the list. I think there's 3 equivalent boxes in the International League Against Epilepsy document which explain some of the possible causes for seizures. So the causes are myriad. There's 1,000 of them, and it's important that you don't miss the one that's causing this child's condition. Important ones that we shouldn't miss then, D, E, F, G, drummed into us from day one. Make sure you've got a point of care, check the glucose, and corrected it if required. Sodium, again, a very important cause. So seizures that are being caused by a child who's hyponatremic are going to be refractory to standard treatment. So you're going to have to correct the sodium. Numbers that we're talking about, so seizures in a child who's got sodium less than 130, personally I would step in and treat, and the treatment's 2 mils per kilo of hypertonic saline, so 2.7% hypertonic, to a maximum of 100 mils. And then repeat. So if you give that over 10 minutes and the child continues to seize, I would give them a second dose. If they're still seizing, at that point I'd probably be getting a gas just to check what the sodium was. And the 2015 NICE fluid guidance kind of allows us in those situations, I suppose, to not wait for a lab sodium. It specifically kind of picked that out as a group to say that the point of care is good enough in this situation. If you're still sub 130, still seizing, you can give a third dose. But at that point, you're starting to ask questions as to what and why. Temperature control, something really important. So Stuart's mentioned a lot in terms of our kind of neuro rehab, neuroprotection side of the house. There are very simple, very basic things that we can do to cool the children down. Child might actually be seizing because they're hot, or they may be hot because they've been seizing for a while. Doesn't really matter. It's not good for their brain, and it's not going to help you stop their seizure activity. So strip them off, get some simple antipyretics into them if you can, and try and get the temperature down. Routine bloods, so essentially that's a screen. So you're looking for your electrolytes, you're looking for signs of infection. You may be looking for more weird and wonderful things. So ammonia in the younger age group. Is this a metabolic condition that's presenting with seizures, which is going to change your management quite drastically? Anticonvulsant levels, if you know the child's on anticonvulsants, then it's useful to actually check the levels, make sure they're therapeutic and it's not just a breakthrough. We have a set of twins who bounce in and out of intensive care, and their most recent admission was because the parents had basically stopped giving them their drugs, and their both levels were subtherapeutic. Pyridoxine's up there, so pyridoxine's always mentioned, again, particularly in neonates, but really in any child up to about the age of 2, you can get pyridoxine-dependent seizures, and a dose of pyridoxine may be the thing that seizes it. That's probably something you're going to want to take specialist advice on, so that's when you start speaking to your neurologist, really. Ingestion, again, does happen, and doesn't just have to be the kind of older teenage group that you perhaps think. Tudor in the room, our last kind of interesting seizure kid who came in, I think was about 14 months, fixed dilated pupils, very agitated, very twitchy, difficult to tell if it was seizure or just agitation. She ended up tubed up in the unit. She got a CT scan, which was normal. She got an MRI scan, which was normal. And then we discovered that she had taken ecstasy. So having asked her family several times, because we were all convinced this was an ingestion, they kept stum because they were worried what would happen to them. So gladly she did very well and just was very over-investigated for an ecstasy overdose. Intracranial pathology, so this may be known or unknown. So do you have a space-occupying lesion? Is your shunt not working? It's important to then consider imaging and moving on towards CT or MRI scan. Again, this picture's up for a couple of reasons. So one, most importantly, to tell you, you can scan your children in a baby pod. The picture quality is fabulous, but if you have a child who's hypothermic and you don't want to take them out and cool them down, CT scanner, certainly in the children's hospital, is always freezing. Just leave them in the pod, it's great. The other reason this is there, so what's the pickup rate? So we're always asking for a CT brain in these children that present in status. How useful a test is that? Are we exposing them to a dose of radiation for nothing? So the guys from Boston published 2018 a case series, roughly 15 years of all their children that had ended up in intensive care, looking at that. Being the American system, perhaps more aggressive than ours in that these children had CT, MRI scan, or both. 98% of their children were scanned, and they found 35% of those scans showed a positive result of some description. 9.8% of those, I think, were something that needed an urgent response. So ADEM that needed steroids, space-occupying lesion that needed intervention, acute bleed that needed neurosurgical intervention. So 1 in 10, to me, I think that's a reasonable pickup rate. So it's certainly worth considering a CT scan as part of your approach to these. So more importantly, have you ever seen a man look more like he's sitting outside the headmaster's office? And actually he is, because that was the service manager's office, and he'd been summoned for a chat. It does say Julie Lewis in the door. It wasn't you, Julie, it was another Julie. So what to do when you're waiting? You've got on top of this, you've got this kid sorted out, they've stopped fitting, they're tubed because they were flat, their airway wasn't protected. So what are you going to do next, I suppose? Well, you've really got 3 choices. If your seizures are controlled, or your first question, are your seizures controlled? If they're not, you're going to have to escalate the therapy. And at that point, you're on the phone seeking advice, I suspect. So you're speaking to your local intensive care, you're speaking to your retrieval team, you're speaking to your neurologist and asking for advice. What would they add in next? If you are on top of the seizures, you're happy that this seizure episode's passed, the child is now ventilated, you can consider extubation locally. So particularly for the straightforward simple seizures, particularly for those children who are just sleepy post-ictal, post-benzos, there is an argument for keeping them locally rather than exposing them to the risks of transport and moving them to another centre, potentially far away. It's not something we do a lot in Northern Ireland, but certainly across the water in England and Scotland, it's much more commonplace practice. So don't be shocked if we ask, we always will ask. If you're not able to, for various reasons, then you're going to have to transfer the child or get the child transferred into your local intensive care unit. So what do you need for transfer? Well, you need an ambulance that's not parked in such a way as it creates rude words. You need a child that's packaged and prepared. I'm not going to steal Lindsay's thunder because she's going to talk a lot about how to package and how to get your children ready to move. Specifically, I suppose around seizures, the important things, you need to be able to assess that the child's not fitting whilst you're moving them. If you've had issues with blood sugar control that has triggered the seizure, you're going to have to make sure you check the sugar en route, particularly if you're a long journey. So shortly after I was appointed as a consultant, we had a child who presented in another unit, required 2 or 3 doses of dextrose for hypoglycemia, and then was transferred up by the local team. Child arrived with us hypoglycemic, having had about an hour and 20 minutes in the back of an ambulance. So to me, that's a situation where you need to plan ahead and say to the ambulance driver, we're going to stop in 20 minutes, we're going to check a blood sugar. We're going to stop in 40 minutes, we're going to check it again. And then we'll get to the receiving unit and check. But if you don't think about it, it'll not be till you arrive at the receiving unit. And by then, that's quite a profound time for hypoglycemia. Similarly, pupil checks. I'm going to talk to you a bit about time-critical transport after coffee and the difficulties, I suppose, of working in the back of the ambulance. But you may want to build in pulling over to the side of the road so that you can check the pupils, make sure this child hasn't started seizing again. You also have to plan ahead for what you're going to do if the child does start seizing. So frontline sedation for us is morphine and midazolam. Midazolam is probably the first drug of choice, so just bolus out of your pump, or do you need other drugs available that you can use? Nasogastric tube, always useful. These kids always have a full stomach, and the last thing you want is them to barf all over you or in the back of the ambulance, because it's just unpleasant. Urinary catheter, not always. I say largely these children are going to be extubated shortly after they get to us, so a catheter may or may not be an in and out drainage may be enough. But again, you don't want to flood in the back of the ambulance, so perhaps it's reason to do it. Temperature control, again, Stuart's talked about it, so making sure these children are kind of normothermic, trying to avoid becoming hyperthermic in the back of the vehicle. And that is it, I think. Any questions?